In this session, I will be discussing about the management of children with COVID-19 having moderate to severe illness. This presentation will be covering the following aspects: case definitions of moderate and severe COVID illness, indications for hospital and PICU admission, general principles of management as recommended by WHO, how to initiate and monitor oxygen therapy, high flow nasal cannula and non-invasive ventilation, case definitions of critical illness, how and when to initiate invasive ventilation, explaining the procedure of intubation and general care of ventilated children, followed by management of shock, and lastly supportive measures and prevention of complication in critically ill children. As per WHO, children with following features categorized into moderate illness. First is the clinical signs of pneumonia, that is fever, cough, fast breathing and mild chest retraction. Children with no signs of severe pneumonia and saturation must be more than 90% on room air. Fast breathing, that is defined by less than 2 months more than 60 per minute, 2 to 11 months more than 50 per minute and 1 to 5 years more than 40 per minute. Children with clinical signs of pneumonia, that is cough or difficulty in breathing, plus at least one of the following, that is central cyanosis or saturation less than 90% on room air, severe respiratory distress, example fast breathing, grunting, very severe chest indrawing and general danger signs, inability to breastfeed or drink, lethargy or unconsciousness or convulsions. Fast breathing, that is as defined earlier, are classified into having a severe illness. So, hospital admission is considered in children with COVID-19 if any one of the following criteria met: presence of respiratory distress or saturation is less than 92% on room air, presence of shock, poor peripheral perfusion, general danger signs, inability to feed or drink, lethargy or unconsciousness, seizures or encephalopathy. Children with high risk for severe disease with milder symptoms such as congenital or acquired heart diseases, chronic lung, liver, kidney or neurological diseases, or on immunosuppressive drugs, congenital or acquired immunodeficiency, those children also needs to be hospitalized. Admission into the intensive care unit should be considered in children with moderate to severe ARDS requiring mechanical ventilation, shock requiring vasopressor support, worsening mental status or having multi-organ dysfunction syndrome. The general principles in the management of children with COVID-19 are as follows. WHO recommends COVID-19 care pathway at all levels should be developed and followed. Infection prevention and control measures should be adhered for all suspected as well as confirmed cases. Endemic infections such as dengue and malaria are to be ruled out as per the clinical setting. Supportive care consisting of ensuring adequate nutrition, hydration and rest. Symptomatic treatment with paracetamol for fever, which is given 10 to 15 mg per kg per dose as and when required, or every 4 to 6 hourly if required. Ibuprofen and other NSAIDs are to be avoided. Children with moderate disease are admitted in isolation to contain the virus transmission. The admission facility may be dedicated COVID health center or district hospital or medical college hospitals. Hematology and biochemistry laboratory testing, electrocardiogram and chest imaging should be performed at admission in order to monitor complication as well as monitor organ function. Oxygen supplementation is given to maintain saturation more than 92%. If inhaled bronchodilators are required, then MDI with spacer is preferred over nebulization to reduce aerosolization. Empirical antimicrobials are not recommended in moderate disease unless there is strong clinical suspicion of a bacterial infection, and it may be considered as per local antibiogram and guidelines in immunocompromised children and children who are under less than 5 years of age. IV methylprednisolone, which is given at a dose of 0.5 to 1 mg per kg, or dexamethasone, which is given at 0.1 to 0.2 mg per kg for 3 days, may be considered in children in whom oxygen requirement is increasing within 48 hours and inflammatory markers are increasing. All the children with COVID-19 infection monitored with vitals, heart rate, blood pressure, oxygen saturation, work of breathing and oxygen requirement of children with moderate COVID-19 for the signs or symptoms of disease progression. Laboratory wise complete blood count with differential count, absolute lymphocyte count, kidney function and liver function tests are to be done daily, and CRP, D-dimers, ferritin are monitored every 48 to 72 hours if the resources are available. Monitor for increased work of breathing, hemodynamic instability, increase in oxygen requirement. If any of the above occurs, consider shifting to a dedicated COVID hospital with tertiary care setup. As of now, there are no established therapies for COVID-19, and also there is no evidence of benefits of giving following drugs to moderately affected children. These are chloroquine and hydroxychloroquine, ivermectin, antiviral agents like lopinavir ritonavir combination, remdesivir, humifenovir, favipiravir, and immunomodulators such as tocilizumab, interferon beta, and as well as plasma infusion. Supplemental oxygen therapy should be given to children with severe acute respiratory illness and with respiratory distress, hypoxemia or shock. The target saturation is more than 94% during resuscitation and 90% for children who are recovering and stable. Nasal prongs or cannula are preferred in children as it might be better tolerated. A surgical mask or hood covered to decrease the risk of aerosolization and droplet spread. If the child is on oxygen through prongs and saturation is less than 90% with minimal respiratory distress, the options in the next level are either a face mask at flow of more than 5 liters per minute providing FiO2 of 40 to 60%, or oxygen hood at flow of more than 5 liters per minute providing FiO2 of 30 to 90%, or we can use Venturi mask which can provide FiO2 28 to 60%, or non-rebreathing mask at a flow of 10 to 15 liters per minute providing FiO2 up to 90%. These devices can be tried before escalating the respiratory support to the high frequency nasal cannula or non-invasive ventilation. Now we go to the management of severe illness. So children with severe disease may be cared in a center equipped with pulse oximeter, functioning oxygen systems and disposables, single use oxygen delivering interfaces, that is nasal cannula, Venturi mask, non-rebreathing mask with reservoir bag. Children with severe pneumonia and danger signs should receive emergency airway management and oxygen therapy during resuscitation to target a saturation of more than 94%, and the same target saturation is more than 90% in a stable child. Empirical antimicrobials should be given within 1 hour of admission whenever bacterial infection is suspected after sending blood culture, and it is based on clinical judgment, patient host factors as well as the local epidemiology. Investigations, complete blood count with differential and biochemistry laboratory testing, electrocardiogram and chest imaging should be performed at admission in order to monitor complications and organ function. Close monitoring of children, vitals, heart rate, respiratory rate, blood pressure, saturation, work of breathing, oxygen requirement should be done for signs of symptoms of disease progression. Complete blood count with differential count, absolute lymphocyte count, renal and liver functions are to be done daily, and CRP, D-dimer, ferritin are monitored every 48 to 72 hours if resources are available. Bubble nasal CPAP may be used with airborne precautions in newborn and children with severe hypoxemia when resources for invasive ventilation are not available. Now we see when and how high flow nasal cannula is used. This heated humidified high flow nasal cannula may be used preferably over CPAP or BiPAP system if the target saturation is not achieved with oxygen delivery devices which have been mentioned above. Switch on the machine only after fixing the nasal cannula, start at 5 to 1 liter per kg per minute and increase up to 2 liter per kg per minute of flow if required. Use minimal flow that makes the baby comfortable and target saturation is 90 to 94%. Monitor heart rate, respiratory rate, saturation and work of breathing. If no response in 1 to 2 hours, then escalation of respiratory support is required. Consider providing a 3-ply mask to cover the mouth and nose of the child while receiving high flow nasal cannula therapy to reduce the spread of aerosol. Coming to the non-invasive ventilatory support, it is offered only in selected children with respiratory distress as the failure rate is very high. Use conventional ventilators for non-invasive ventilation with a non-vented oronasal mask or helmet, or as non-invasive ventilator with single limb and vented mask have high risk of aerosolization. Connect a bacterial or viral filter at the exhalation port and use the lowest possible PEEP to achieve the target saturations. Monitor closely and intubate if the patient deteriorates or there is no improvement in 1 hour. Coming to the severe illness, children with COVID-19 infection having any one of the following classified as critically ill: acute respiratory distress syndrome as defined by the pediatric ARDS guidelines from the Pediatric Acute Lung Injury Consensus Conference, sepsis who has suspected or proven infection and greater than 2 age-based SIRS criteria, or septic shock as manifested by hypotension or any 2 or 3 of the following. Those are altered mental status, bradycardia or tachycardia, prolonged capillary refill or weak pulse, mottled or cool skin, petechial or purpuric rash, high lactate, reduced urine output, hyperthermia or hypothermia. Now coming to the management of child with ARDS. Children with COVID-19 and mild ARDS, a trial of high flow nasal oxygen therapy or non-invasive ventilation like CPAP or BiPAP may be used with strict adherence to the airborne precautions. High flow nasal oxygen therapy or non-invasive ventilation are to be avoided in children with hypoxemic respiratory failure and hemodynamic instability or multi-organ failure or abnormal mental status. Children receiving a trial of high flow nasal oxygen therapy or non-invasive ventilation should be cared for and monitored by persons who are experienced with high flow nasal oxygen therapy and NIV and capable of performing endotracheal intubation in case of deterioration or non-improvement, that is after the trial of 1 hour. In children with COVID-19 who are critically ill, intubation is considered if any one of the following conditions present: severe respiratory distress, that is not able to maintain saturation more than 90% on non-invasive oxygen supplementation, when PaO2 by FiO2 ratio is less than 200 or PaO2 by FiO2 is less than 300 with hypotension requiring vasopressor support, or having a Glasgow coma scale of less than 8 with threatened airway. Intubation in COVID-19 children done with all airborne precautions and the following steps are adhered strictly. The most skilled member of the team should be identified at the beginning of each shift for performing intubations. Pre-oxygenation with 100% FiO2 with non-rebreathing mask or nasal prongs. Bag and mask ventilation is avoided due to risk of aerosol generation. If needed, it can be given by connecting a viral filter. If readily available, intubation should be performed using a video laryngoscope. Cuffed endotracheal tubes should be used to avoid peritubal leak and dissemination of aerosols. So, rapid sequence intubation should be done, and during induction monitor for hemodynamic instability and use fluids and vasopressors if required. X-ray chest is ordered to confirm the position of the tube. After intubation, appropriate cleaning and disinfection of the equipment and environment should be done. The following are the general ventilatory strategies recommended in managing the intubated children with COVID-19. Target a lower plateau pressure, that is less than 28 cm of water, and a lower pH is permitted, that is 7.15 to 7.30. Tidal volumes 3 to 6 ml per kg of predicted body weight in case of respiratory system with poor compliance, and 5 to 8 ml per kg of predicted body weight with preserved compliance. In children with moderate or severe ARDS, a trial of higher positive end expiratory pressure is given instead of lower PEEP, and it is to be individualized. Application of prone ventilation when PaO2 FiO2 ratio is less than 150 or oxygenation index is more than or equal to 12 or oxygenation saturation index is more than 10 is preferably done for 16 hours per day. That may be considered for pediatric patient with severe ARDS where sufficient human resources and expertise are available. Referral of children who have refractory hypoxemia, example PaO2 FiO2 ratio less than 50 for more than 3 hours or PaO2 FiO2 of less than 80 for more than 6 hours despite lung productive ventilation for extracorporeal life support. The general care of the ventilated patient children includes always use fresh, preferably disposable ventilator circuit for every new patient. Use viral filter in the expiratory limb of the circuit. Heat and moist exchanger to be changed every 48 hours or when visibly soiled. Avoid disconnection of the circuit which causes loss of PEEP, atelectasis, increased risk of infection of the healthcare workers. Use closed suctioning technique and avoid routine suctioning to reduce the aerosol generation. Appropriate sedation should be ensured and intermittent muscle relaxants may be used, although continuous infusion of neuromuscular blockers are not routinely recommended. Conservative fluid management strategy must be followed for ARDS patients without tissue hypoperfusion and fluid responsiveness. The management of sepsis and septic shock includes standard care consisting of early reanimation and the following treatment, which are done immediately within 1 hour of reanimation. So, initiation of fluid bolus, antimicrobial therapy, vasopressors for hypotension, and central venous and arterial catheters should be based on the resources availability and individual patient needs. During resuscitation for septic shock in children, give 10 to 20 ml per kg of crystalloid fluid up to 60 ml per kg either normal saline or Ringer's lactate as a bolus in the first 30 to 60 minutes. Hypotonic solutions and colloids are to be avoided. If there is no response to fluid loading or signs of volume overload appear, then one has to either reduce or discontinue the fluid administration. During resuscitation, consider using dynamic indices of volume responsiveness such as passive leg raising, fluid challenges with serial stroke volume measurements or variation in systolic pressure, pulse pressure, inferior vena cava size or stroke volume in responses to the changes in the intrathoracic pressures during mechanical ventilation to guide the volume administration. If signs of fluid overload are apparent or the shock persists after 2 fluid bolus, start vasopressors. If the central venous catheters are not available, vasopressors can be given through the large peripheral vein and closely monitor for signs of extravasation, local tissue necrosis. If extravasation occurs, stop infusion and vasopressors can also be given through intraosseous needle. In children, epinephrine is considered as first line treatment while norepinephrine can be added if the shock persists despite optimal dose of epinephrine. If signs of poor perfusion and cardiac dysfunction persist despite achieving MAP target with fluids and vasopressors, then consider starting an inotrope such as dobutamine. The supportive care of the critically ill child with COVID-19 infection includes the following measures. Head and elevation. It may be avoided if child has poor perfusion or shock. Oral hygiene with antiseptic mouthwash twice daily. Early enteral nutrition starting within 24 to 48 hours of admission. Glycemic control to maintain blood glucose in the range of 100 to 180 mg per deciliter. Insertion of Foley's catheter for accurate urine output monitoring. Insertion of appropriate size feeding or Ryle's tube for enteral feeding as well as medications. Care of central venous catheter to prevent catheter related bloodstream infection. Position change every 2 hours to prevent blood sore. The following measures are followed to prevent complications in the critically ill children. Daily assessment for readiness of extubation and sedation window to be given to reduce the number of days of mechanical ventilation. Head and elevation, closed suctioning, changing the circuit if it is soiled, changing heat moist exchanger when malfunction, when soiled or every 5 to 7 days to reduce the incidence of ventilator associated pneumonia. Anticoagulant prophylaxis with low molecular weight heparin or heparin to prevent deep vein thrombosis. Sterile insertion techniques must be followed while placing the central catheter and removal of central venous catheters considered if no longer is required in order to reduce the catheter related bloodstream infections. Positioning every second hourly to prevent bed sores. Yearly enteral nutrition preferably within 24 to 48 hours of admission and administration of H2 blockers or proton pump inhibitors in patient with risk factors for GI bleeding to reduce the ulcers as well as bleeding. The risk factors include mechanical ventilation more than 48 hours, coagulopathy, renal replacement therapy, liver disease, multiple comorbidities and higher organ failure score. Actively mobilize early in the course of the illness as soon as the child is stable to prevent the ICU related weakness. Summarizing, children should be categorized based on signs and symptoms and management protocol to be followed according to the severity of illness. Infection prevention and control measures should be followed for all suspected and confirmed cases. Oxygen therapy, high flow nasal cannula are the tools for respiratory support in children with moderate illness, non-invasive ventilation and invasive ventilation for ARDS, and airborne precautions have to be followed in all cases. Low tidal volume, low P-plat, moderate to higher PEEP, permissive hypercapnia and prone ventilation are the main ventilatory strategies. Antimicrobials are administered only if bacterial infection is suspected or in children with sepsis and septic shock. Close clinical monitoring of vitals, heart rate, respiratory rate, blood pressure, saturation, work of breathing and oxygen requirement in any category is paramount clinical importance in the management of COVID-19. Antivirals like remdesivir, tocilizumab and plasma therapy are to be used only in clinical trial settings. Thank you.